Thanks to everybody for joining in today. Today, Dr. Muzzamal Habib from Boston will be speaking to us on COVID plasma therapy. We have an excellent panel group, including Dr. Bushra Jamil from Aga Khan University, Professor Imran Fazl from the Military Corps in Rawalpindi, and Dr. Peter LaCamera from St. Elizabeth's Division Chair of Pulmonary and Critical Care Medicine in Boston. A couple of housekeeping items. We will be taking questions towards the latter part of the hour after we've heard some seminal comments and some didactics from our panelists. If you could please make sure to mute yourself, each and everyone, including the panelists, except when you are speaking. That would ensure a smoother flow. If you have any questions, you can type them in the Q&A tab at the bottom of the screen. You're obviously welcome to add stuff in the chat forum as well. So with that, let me take it over, send it over to Muzzamal. Muzzamal, go right ahead, please.
Thank you very much, Majid, and thank you everybody for joining. So it is a very interesting topic, COVID convalescent plasma, or at least it is a kind of interest. I have a kind of real interest in this one. Before we get started, as far as any disclosure is concerned, I do not have any financial disclosure. Yes, we have worked on a website which does kind of help people to perform and kind of register patients if they are providing this treatment. But there is, again, it's free to use. There is no financial conflict from that point of view too. So before we get started formally, I will go through our learning objectives for today. I will go through a history of convalescent plasma, and we will discuss past uses. Then we will touch recent uses of convalescent plasma in COVID-19 and potential for this treatment in future. And also, if somebody wants to start convalescent plasma, we will discuss. We have people who have either set up primary sites like Dr. LaCamera and also Professor Imran from Pakistan, just to we will avail their experience and take their advice how to get started if somebody wants to start this program in a structured way. So in the long term, we get a data which can be used in a meaningful way. As far as COVID is concerned, yes, we do have some reprieve as far to some extent as far as globally or internationally. In United States, we are still seeing quite a high number of COVID patients. I was just looking on kind of in terms of crunching numbers, just at a basic level. We obviously have a highest number in globally now, kind of just crunched for the population of 382 million. Our number is quite high for more, I mean, almost for 1,500 per 100,000 people. And similarly, unfortunately, we have touched this kind of, we have lost 800. That was the news yesterday. 800,000 people globally to this disease. When I looked into the numbers, I just Googled it for Pakistan. So obviously, we peaked in March. You guys followed us for a few months, kind of June 16, probably around that time you guys peaked. And I mean, thanks. It seems kind of you do have a little bit less number of patients, reasonably less number of patients. Not sure what's the reason, but it's blessing. So having said that, it should not be taken as a kind of we have conquered, we have won. This is a slide which I took, I think it was about 10 days ago when I presented the same topic to International Medical Students Federation. So we had a percentage of positive tests just under 2%, 1.5%, but due to kind of get-togethers and kind of improving weathers, and also what was going on with this kind of after George Floyd's death, people were kind of getting together, getting on the strikes, etc. So there was slight increase in Massachusetts. We had seen our number above 2%. Similarly, we do have a few areas, kind of where we see still the percentage of positive tests going up to 11.2%. So we are going to have peaks and troughs. I mean, whenever people, obviously, I think at this stage they are following. In United States, nearly 50% of people are using masks, and I mean, but eventually people will feel kind of isolated or kind of not to be able to be complying for too long. And whenever they come out and we do not have vaccination, that risk is going to be always there. So we have to be vigilant. We still have to work. And that is the reason we are looking on all modalities of treatment, whatever we have on our disposal. Obviously, we don't have anything dedicated or specific. We are making small milestones, making small wins, but that is really what we expect and what we have seen so far, and what is a realistic expectation unless we have some good effective vaccination. So convalescent plasma is obviously just one of those modalities in our kind of list of armamentarium. So we will just focus today's discussion on convalescent plasma. So this is not obviously a new treatment. First use, I read somewhere it was even tried in diphtheria and tetanus, but real documented kind of published was around 1896, and then real use which kind of made it popular was Spanish flu in 1918. And obviously, they did not have all kind of fancy stuff what we have, plasmapheresis, etc. now. So they were using convalescent whole blood, later on convalescent plasma, and also pooled human immunoglobulins, etc. I mean, yeah, now we have a polyclonal and monoclonal antibodies, but not for COVID. So that was obviously not treatments which were available 100 years ago. So it was used in Spanish flu. We will discuss its use in Spanish flu. And recently, from late 1980s or 90s, it had used in SARS, as well as Middle East respiratory syndrome and Ebola virus. It had tried in respiratory syncytial virus as well. And there was some mention of West Nile virus. I have not seen too much publications on that, but it had been tried. So I will go through kind of what was the use in terms of Spanish flu. It was a meta-analysis in which they were able to find 8 studies. They include a kind of the total number of patients were just over 1,700, and there was mortality benefit. What they noticed, if people were of younger age, it was kind of beneficial. Similarly, if they were seronegative, it was beneficial, but there was not much difference in terms of mean plasma volume used, etc. So that was kind of the effect what they were able to document. I have a better meta-analysis, which we will kind of, this one is a recent one. It was published sorry, let me see what's the reference. International Journal of Infectious Diseases. It's a very recent one, and it was, they were able to find 15 studies. Again, they looked use of convalescent plasma in severe viral diseases, diseases, not only SARS, not only MERS, but kind of looked into other diseases too, wherever they can find studies. So they were able to find 15 studies, and that was quite a decent number. They were able to find a total kind of in a control group of just about 2,000 and an intervention group of 560 patients in total. Whereas if you look into the mortality benefit, there was a mortality benefit then with the kind of p-value of 0.007. And if you look into the studies, they had included SARS, a decent number of patients, not huge, kind of about 89. Similarly, they included Ebola virus. I will discuss Ebola viral. I will touch Ebola virus was not a success as far as convalescent plasma is concerned, and there were reasons why. Similarly, they kind of had looked into Spanish influenza. So they have included kind of about 1,500 patients, both kind of control as well as intervention group. H1N1, it had been tried. It had also been tried influenza. So kind of definitely in majority of those studies, you can see there was a beneficial effect, most of them with a significant p-value, where except Ebola, where they did not, there was not, it was not a success story. Again, these were older studies, and what authors have mentioned as far as limitations of this meta-analysis is concerned, quality of studies were either medium or poor. So they were not really kind of randomized controlled trials. And I mean, there was also heterogeneity. And even when they took out those studies where there was kind of heterogeneity, which was more than acceptable in the recent and kind of current day and age, they were able to still see this trend and kind of statistically significant benefit for using convalescent plasma compared to the control group. So then it had been tested in MERS. Unfortunately, they found very few people with a significant titer of antibodies against the MERS, Middle Eastern Respiratory Syndrome. So they tested almost 247 people. They were either the providers or families of patients who were at high risk, and kind of they were able to find only 12 out of 247 patients with a decent antibody titer. So it was not a success. There was no clear explanation. It's probably just the nature of disease. It may not induce such a strong immune response, or they also said probably they were testing a kind of more quite a few weeks after patient had already been exposed, and maybe their immune system and antibodies have kind of weaned. So that was one reason for not having this success. But that was not a success story. Similarly, Ebola. Ebola is the pathogen is a biosafety level 4 pathogen, which needs a lot of safety measures in order to come up with level 4 microbiology lab. And obviously this was happening in the very poor area of the Africa. And also there were a lot of rumors, there were kind of safety concerns for researchers as well as facilities. So there was also lack of plasmapheresis equipment. And I was not surprised to hear that that can be a problem in Pakistan too, because one of my friend who works in a reasonably bigger town, he told me they don't have plasmapheresis machine equipment. And similarly, the studies were not that structured, though kind of in the last meta-analysis, which I showed you, and if there were few studies in which they were able to get the reasonably done studies, there was a trend towards improvement, but not a success story as far as Ebola is concerned for COVID convalescent plasma. So now I think we are moving towards its use in COVID-19 studies. This was the first study which came from China, or at least that was kind of first one which was published. And it's a prospective one. It's not a randomized. They don't have a kind of a control. It was just their safety and use of convalescent plasma in 10 patients. This is just kind of their demographic of patients in terms of age as well as days of admission, and if they had other, let me minimize it so you can see, sorry. I mean, if they had a comorbidity. So in terms of methods, they had 10 patients with the severe disease and confirmed COVID by RNA, by PCR. And as far as donors were concerned, they have taken their cutoff value was 1 into 60 titer for antibodies. They have not included anybody, or they have not used anybody or accepted anybody as a donor if antibody titer was less than 1 to 640. And as far as volume of convalescent plasma was concerned, they have used a 200 ml as a convalescent plasma. I know in a different studies, people have used even 375 or 400 are different volumes, but that was their volume. And they continued a rest of antiviral, and I was looking on their protocol. They have a few drugs, which we are not familiar with, but they continued with, they followed their local advisors, local guidelines, and that did include antiviral as well as antibiotics. So normal kind of rest of the treatment continued. And the primary endpoint for this study was not a mortality, etc. It was primarily just to evaluate the safety of convalescent plasma in COVID patients, and they concluded it was safe. There was not any significant side effects or any kind of transfusion-related uh, adverse outcome. Uh, so that was what I mentioned in terms of antiviral treatment. This is Arbidol is antiviral. I think it's kind of approved only in Russia and China, but they did have other patients, ribavirin and a few other antivirals too. And antibiotics were also there. And they have used steroids. It was the trial conducted before that British trial came out, in which they did show beneficial effects of dexamethasone. So few of their patients were on steroids as well. Uh, other clinical endpoints that was not primary endpoints. They did see increased lymphocyte count. Obviously, we see in patients with COVID a decrease in lymphocyte count, which is not unique to COVID, because we see similar phenomena in other acute viral diseases too. They also had seen other inflammatory reactants like protein C, their decreased value after convalescent plasma transfusion, and there was some varying degrees of resolution of lung lesions. That was obviously going to be a little difficult to quantify based on only 10 patients, and not a basic quantification what was the lung lesions and kind of how many patients had, and it did vary. So what they also see, their patients came kind of viral load was undetectable in 7 patients post transfusion. So what they concluded, there is need of further research to determine the timing of transfusion and amount of transfusion. And the second study also came from China. They had only 6 patients, and what they had noticed in their patients, there was kind of appear resolution of ground glass opacities in five patients, and resolution of viremia in 2 patients. Again, not a huge study, only 6 patients, and but still showed the same results. It was safe to use it, and there was a trend towards improved outcome. So this is the last study, which I looked on, I searched the literature on PubMed and few other sources about 10 days ago. And this was something I had not seen at that stage. So this is the first study which is randomized, and it followed WHO criteria for the kind of level of sickness, level of acuity, etc. for COVID patients. For example, if patient is discharged, that patient gets only score of 1, and if somebody passes away, that gets a score of 6. If somebody is on a ventilator, that gets a score of 5. So it did follow those WHO guidelines, and they randomized. So total they had 148 patients. They were planning to enroll 200 patients to make that study statistically powerful enough to determine the mortality difference. Fortunately or unfortunately, after 148 patients, and out of those, after enrolling 130 patients, uh, it was conducted mainly in China. So I mean, they from March 24, they had not admitted any patients. They could not enroll any patient. And after waiting for about a week and not having any new patient, they decided, okay, they are going to do a statistical analysis and just kind of see what the results are. So by the time they were done, with the randomization, they had randomized 52 patients in the arm which was going to receive convalescent plasma, and 51 patients were randomized to a standard treatment. They had a good follow-up. One patient was discontinued kind of on the intervention group, and one was excluded because that patient ended up receiving convalescent plasma after enrollment to be in the other arm where he was not supposed to get convalescent plasma. So their randomization seems to be really good one in terms of if you look on those numbers. Their median age was not different in either group, convalescent plasma group or a control group. Similarly, other demographic features were somewhat similar. There was not any disparity or huge difference in one group versus other group, whether they were hypertension, whether other risk factors for poor outcome for COVID, like cardiovascular disease or CVA, diabetes, etc., etc. So it was randomized in a good way, and it was structured in a good way. So what they have found, it was relatively, it was not a negative study, but again, there are limitations which we will describe. So overall, they had seen a slight trend towards better outcome, but it was not statistically significant. Uh, when they did a subgroup analysis for severe disease, and severe disease was defined by patients who were requiring oxygen and other support, but not to be bad, not to be bad enough to be in ICU, for to be monitored closely, and also not to be on ECMO or not to be on a ventilator. So in this group, they did see a trend, a decent trend towards improved outcome with the convalescent plasma. Again, they did not have too many patients. Study was not, at least the number of participants was not large enough to come to a conclusion whether it was, I mean, the p-value was not significant. So it's, again, statistically not significant, but trend towards better outcome or improved outcome with the use of convalescent plasma compared to control group. Uh, as far as life-threatening disease is concerned, which they had defined patients to be in ICU requiring 24-hour monitoring, or to be on ECMO, or to be on a ventilator, probably they were already too far advanced. They have not seen any improvement in terms of those patients combined. So, so again, overall negative study in patients with the severe disease, a trend towards better outcome, and as when kind of it was done in a severe patient, a life-threatening disease, no difference in convalescent. So it's probably a real life and a real experience. We should be expecting the outcome from convalescent plasma. Uh, because the studies which we saw earlier coming from China, the smaller number of patients, not losing any patient, seem to be too good to be true. But again, I think we still have a hope, and we should be expecting small achievements, small milestones with each treatment, and probably by combining other modalities too, eventually with the good anticoagulation, with the dexamethasone, with the convalescent plasma, probably we will see uh, improved outcomes. So for this slide, I will probably need help from Dr. LaCamera. So these are the current trials which are ongoing in United States and Canada. So this, I will let the viewers go through this. They are I mean, they have enrolled 55 in this one. The first study, it's a single arm, whereas a few of other studies, they have, I mean, again, as far as patients populations are concerned, it could be hospitalized without mechanical ventilation, and also a subgroup of hospitalized with mechanical ventilation. These are two tracks. Uh, in other studies, they were expecting to enroll 1,200 patients and hospitalized non-intubated. I hope we never see any surge in fall, and we never see, so that may be a problem because I mean, same thing happened in our hospital. We were kind of planning to ramp up our convalescent plasma enrollment in expanded access use, but fortunately, I mean, COVID patients simply disappear after March, so we have not been able to enroll too many. Similarly, there are a few other trials, which John Hopkins University trial. Again, they were even trying to enroll those asymptomatic with negative PCR, but high risk to exposure, for example, somatics, as well as family members, and using convalescent plasma on them in case if it can be used as a prophylactic or it can be used as a preventive modality, not only the treatment modality. This was expanded access convalescent plasma. We were part of one of the site. Dr. LaCamera is our primary investigator for that. He will elaborate on this. This again is not randomized. It doesn't have a control. It simply is primarily just to see if everything is safe, if there is a trend towards improved outcome. And there were almost 3,000 sites and quite a decent number of physicians. And as far as patients are concerned, there were, by the time I saw it last, it must be more than this now, because I took this screenshot maybe 10 days ago. Similarly, more than almost 60,000 infused convalescent plasma. And as far as criteria was concerned, it was quite lax compared to what we have discussed previously to have an antibody titer of 1 into 640. I mean, in this study, they have said, anything above 160 is fine. Okay, so I mean, again, their diagnostic test, like our normal practice these days, was nasopharyngeal swab, as well as for donor serological test after recovery, as well as a clinical recovery for those potential donors. Symptoms of infection should have resolved 14 days prior, and if they were female, either they should never have been pregnant, or HLA was tested and to be negative. And testing was also performed. As I said, the titer above 160 was recommended, but if ABO incompatibility was there, then even 1 into 80 was acceptable or accepted. If titers were not available, consider storing a retention. They had even said, okay, go ahead, use it, and then kind of do a testing later on. So I think I will skip this for our I had kind of presented this one for our medical students, but I think I will leave this for Dr. LaCamera and Professor Imran to go through. If somebody has to establish a successful program, what are going to be the pillars and what needs to be done. And I was told to finish the presentation in about 30 minutes. And so I'm leaving the rest of the time for our expert panel. And I know Dr. Tariq Shahab had also joined as a panel. Thank you. And I will, Dr. Majid, it's back to you.
Great. Thank you so much, Dr. Habib. Yes, indeed, Dr. Tariq Shahab, one of our esteemed cardiologists, also based in the US, is also joining. Thank you very much. In fact, there's a question directed towards him as well. But before we take that, we actually have a number of people who have had some experience with convalescent plasma, both in the US and also in Pakistan. Dr. Bushra Jamil from Aga Khan University has some data to share from Aga Khan University. Dr. Imran Fazl has data to share from the military hospitals in Rawalpindi. And then Dr. LaCamera has experience to share as well. Why don't we start with Dr. LaCamera? Would love to hear your comments and any other insights you have. Thank you.
Yeah, no, sure. Thanks for inviting me and allowing me to participate. So just for an introduction, I'm Peter LaCamera. I practice pulmonary and critical care medicine in Boston. And, in the US, as I think most people know, the Northeast was hit early and really hard by the COVID pandemic. And so, during those early days, particularly late March and early April, everybody really universally was just scrambling for therapies that might be helpful. And there was, as everybody knows, an enormous sort of amount of enthusiasm towards hydroxychloroquine, which, ultimately came and went, thank goodness. And then convalescent plasma showed up on the scene relatively quickly as well. And so, we give a lot of credit to sort of 3 different institutions, the Red Cross, the Mayo Clinic, and then I don't know what that we'll call the federal government an institution, but, they combined resources to set up, as Muzzamal mentioned, this expanded access program. And so, in the early days, really the first week or two, for a patient to be able to receive convalescent plasma, he or she had to have a specific donor. So it was the responsibility of the physicians, the friends, the family, et cetera, to go find a specific donor that's obviously, blood type compatible. And then that we would pherese that donor, take that donor's plasma and infuse it into the specific patient. But quickly that transitioned to essentially a bank being created. So anybody could, who had recovered from COVID could present to a pheresis center, donate, and then there was a plasma bank that was created. And when one needed plasma for a specific patient through the Mayo's expanded access program, that request could be submitted and the plasma would be delivered. And the time frame on the delivery was variable, honestly, and a lot of it had to do with blood type, to be frank. So it was anywhere from 1 to 5 or 7 days, actually. And so, we were one of the really first participants in Mayo's program, and ended up transfusing a number of patients in the ICU setting throughout the month of April and early May. A smaller number of patients, on our floors, and our experience was mixed, frankly. I mean, what I can say is that I don't think we look back on any of the patients that we infused as with any concerns that it caused harm necessarily. We didn't see any sort of acute transfusion type reactions, et cetera. But it's hard to say obviously in a non-randomized setting, whether or not the therapy provided any help. The recent data that's been published has been mixed. So, the data from the Mayo program, suggests that if a unit of plasma has high titers and if a patient receives it early, that it is in fact helpful, or at least there's a favorable signal there that it's helpful, but it doesn't seem to be sort of a home run, so to speak. So just within the past number of days, as I'm sure many people have heard, the FDA has moved towards closing down the expanded access program. And the rationale there is really to sort of force the hand of physicians and scientists to really complete these randomized studies that Muzzamal referred to. So there are scores of studies out there. So we're participating in a study that's being organized and sponsored by Brigham and Women's. We've also been invited to participate in a study that's being organized by the Johns Hopkins. I mean, there's scores of studies, but enrollment has been impossible because there's been this guaranteed access program. So it's hard to convince patients and families to enroll in a randomized trial that involves a placebo when there's the expanded access program that ensures that any given patient will actually receive convalescent plasma as opposed to a placebo. So that's, while the expanded access program has been looked at as being really terrific and a great resource, and we're hoping to learn more and more from it. The sort of the downside to it has been that it's interfered with our ability to complete randomized trials to really get at the question of whether or not plasma, in a structured scientific way, is helpful or not.
Thank you very much, Peter. So if I understood correctly, as of today, if a clinician in the US was considering potentially giving convalescent plasma to one of their patients, the best next step forward would be to try and reach out to one of these several investigators to try and participate in a randomized trial, because the expanded access program is now shut, correct?
Yeah, I don't know for a fact that it's actually closed at this very moment, but that's the direction that it is heading. I have to confess, I've been off service for a week and a half or so. So I don't know where things stand at this very moment, but that's the direction that it's heading. Because what was happening was the FDA was on the precipice of considering plasma a emergency, giving plasma emergency use authorization, much like it did remdesivir. So if something gets EUA, then physicians can use it. It doesn't need to be sort of, officially FDA approved, but physicians can use it, as we've been doing with remdesivir, even though that's not FDA approved. So the federal government was on the verge of transitioning plasma to this other status, this EUA status. And right before they were about to do it, the NIH recommended to the FDA that it sort of puts the brakes on that transition. Again, with the idea that we're trying to push people more so into randomized trials, which, in retrospect, would have been nice to have happened a handful of months ago. I mean, it's great that so many people, right, as Muzzamal mentioned, there's now over like 90,000 people who have received plasma, which I hope we can look back on and say that was a great intervention we were able to provide them. But again, the sort of the flip side to that is that we still don't have the data that we really need to speak intelligently about the efficacy of plasma.
Great, thank you. Yeah, and nicely alluded to, of course, the how torn we as physicians can feel, particularly in the context of an unprecedented time with pandemic and with all the talk about crisis standards of care and whatnot. Whether to help the here and now or really invest in finding out whatever the ultimate truth might be. Looks like Muzzamal has some thoughts to share about how to get access to convalescent plasma as well. Go right ahead, please.
No, I think it was somebody just asked the question that is there any centralized data for the potential donors are on those lines in United States or in Pakistan. In United States, Red Cross serves as the main database holder or the organization which has a database of patients with the blood group and also potentially patients who have recovered and can be potential convalescent plasma donor. Am I right, Dr. LaCamera? Is that true? Red Cross serves as a primary database source?
That's correct. Anybody who's interested in donating could just go onto the Red Cross site and provide their information, and then the Red Cross contacts them. There's a bunch of screening questions that are asked, and then if they're qualified, the Red Cross will contact that person and schedule a pheresis appointment, essentially.
Okay, so on the same lines, I know as far as I know, there is not any structured database in Pakistan. So that was the reason for starting a website called convalescentplasmabank.com, in which we have tried to keep the same security and privacy for patients. So patients' numbers, name, etc., date of birth never get exposed to public, but potential patients who have recovered, they can register as a donor, as well as physicians who can register their patients when they are recovered or close to discharge as potential donors, and they can be contacted by future patients as well as physicians when they need for any of their future patients. So if there is any uptake on that one, if there is any interest in Pakistan or anywhere, we are in a position to offer that on no fee and no cost basis, just as a kind of a good Samaritan on our part.
Excellent, thank you. All right, let's move over to Pakistan now, where we have two senior clinicians available to share their institutional data. First, I'll invite Dr. Bushra to share her data from Aga Khan University and also her thoughts as an infectious disease expert. Dr. Bushra.
I have the interim report here with me. I can share the slides, but I can just tell you verbally as well. So it was a small study on convalescent plasma, which was started 2 months ago. And 30 patients were recruited in the treatment arm. And almost half of them were in ICU. So they were fairly sick at the time of recruitment. So as clinicians, the ID physicians basically selected patients for convalescent plasma if there was any contraindication to the use of tocilizumab, which happened to be our drug of choice for seriously ill patients who were about to be intubated and had CRS. In the initial days, remdesivir was not available, so convalescent plasma was a useful drug for us to use in situations where tocilizumab was contraindicated, and later on when remdesivir became available, when remdesivir was contraindicated. We also used it in patients who continued to deteriorate despite getting their doses of tocilizumab and later on remdesivir. So overall, there were no major adverse effects observed in the treatment group, and mortality was 30% in the treatment group and 70% in the control arm. Because both these groups received either tocilizumab alone or with remdesivir. Almost all of the patients received steroids, and a large majority were on anticoagulation, either on enoxaparin, heparin, or rivaroxaban. So good experience for us. It was something to fall back on. So we found it very useful.
Thank you, Dr. Bushra. Are you continuing to use it now with the expanded access to remdesivir, or are you continuing to only use it as a fallback option? It sounds like the experience was fairly positive. Have you thought about perhaps using it more of a frontline agent? Any thoughts about that?
We could have done that, but the trial had to be stopped because the principal investigator included the PRNT as a component of the trial. So we don't have plaque reduction neutralization test available here. So the trial had to be stopped, and plasma has not been used outside of the trial setting at AKU. Although actually as clinicians, we miss having plasma in our armamentarium.
Well, thank you. That's great to hear, and also admirable that AKU was able to really use this in a structured manner. In the midst of those testing times, in the context of a clinical study, then something we can all learn from. Great, Professor Imran Fazal from Rawalpindi. We'd love to hear your experience and thoughts as well. You may have to unmute yourself. Let me see if I can help with that. There you go. Now you're unmuted.
Yes. So we have been dealing with COVID patients over here in Rawalpindi, and we had the biggest dedicated COVID center in the country. So we had a varied experience with plasma and with tocilizumab, as well as with stem cells, as well as with remdesivir. So it was rather difficult in the beginning that once everything was not available frequently, and we started patients by doing various sort of protocols. And then later on, for the purpose of plasma, we created a propensity score matching, and then we propensity score matching, we randomize it into two groups and then analyze it. Just to share the methodology, the inclusion criteria which we had was that the patients who were COVID positive on PCR should have either CRS and presentation or during hospitalization, and can be age of 10 to 80 years and had at least one session of plasma. Then the exclusion criteria was death within 48 hours, severe septic shock, congestive heart failure, and those receiving anti-thymoglobulin or hematopoietic stem cell in the last 6 months. Patients receiving other investigation drugs like tocilizumab, remdesivir, and mesenchymal stem cells, they were also excluded with the help of this propensity scoring. Basically, then we use the statistical analysis in patients with moderate, severe, and critical COVID infections. And we had actually, initially we had a number of patients were about 350. About 350 patients we had, and amongst them, we thought that 280 were eligible. There were certain, rest of the patients were excluded. And amongst these 280 patients, 71 patients receives plasma exchange and 209 did not receive plasma exchange. So we actually matched 45 individuals from each group with 1:1 propensity score matching. So that was our method for randomization. The other thing which I like to share was that we do have a bank of donors, and the patients who suffered from COVID-19 and they had recovered, they were on our donor list, and we were collecting their samples for antibody titers and antibody testing, and whosoever had positive, they were included in therapeutic trials. So in we had this disease all over the country. So what we did was that the method of collection was of plasma. We divided into two parts. One was a simple plasmapheresis, and we collected plasma and then utilized it. And the other was the simple blood donation and then separating RBCs as well as plasma. So we found both the methods were utilizable, specifically in terms of logistics and in terms of time. So the results were really quite interesting. The people who were in uh, moderate cohorts, they had basically the results were almost the same. But as the disease became more severe, the benefits of plasma were definitely more. In patients with severe COVID, what we found that 10% of the patients had reduced mortality, and 10% of the patients had better responses in severe. Although the patients with critical COVID, the mortality benefit was 50%. So this has a very significant statistical value. So we think that appropriately select patient selection and at appropriate time, once we use plasma, this is a very useful armamentarium. The difficult part of all this is that at times patient is with there is a one patient and are different therapies available to these patients. So we have been using all these therapies with our patients, and then we have randomized it with the help of propensity score. So I can say with confidence that we are still using plasma therapy for our patients, and we feel that this is possibly one of the first line therapy available for our patients.
Thank
If
you
I
very
have
much.
any question, please let me know.
Yeah. Thank you, Professor Fazal, for sharing all of that. Of course, and when we have observational data and an inability to sort of prospectively randomize patients, of course, propensity matching is a nice way and a well recognized way of trying to address as many confounders as one humanly can. Obviously, not exactly the same thing as a prospective randomized study, but certainly these data are very encouraging. Are you looking to publish these data as well?
Yes, we have already sent it, and the web form is already published, and we are looking forward for the actual publication in maybe in one of the good journals. It
That's
has
excellent.
already been sent.
Wonderful, thank you. And Dr. Bushra Jamil from Aga Khan, are you looking to publish those data as well?
Yeah, it has been submitted.
I see, I see. Great, thank you very much. Well, I would like to have, let's see, we had a cardiologist here with Dr. Tariq Shahab from the US, and there's a question specifically directed towards the possible association between COVID-19 and cardiac complications among young patients. I'd like him to take that question and, of course, also share his thoughts about the subject at hand. Dr. Shahab, please go right ahead.
Thank you, Majid. First of all, I would thank the panelists and also the organizers to give me opportunity to speak, especially Muzzamal and Majid, and respected panelists, Dr. LaCamera and Professor Imran Fazal and Bushra Jamil all have already said quite interesting things. But for the audience, especially in Pakistan, although I'm an interventional cardiologist, but I have deep interest, as most of the scientists and doctors have, towards managing this pandemic COVID-19, which has been going on for the last several months now, as you all know. As you know, that I have created a website named rttier1.com on which we had released videos on each and every topics of COVID-19 for the education of the general public. We also have a Facebook page named @RTCare1 that anybody can go and find, and we are followed by 100, 200, 300,000 people, especially from Pakistan, because most of these video series were done in Urdu. There were some that was also done in English. And we have different panelists from time to time come and give their input as well. Saying that all of you have reviewed the studies and what your experiences have been. Unfortunately or fortunately, the convalescent plasma therapy has been going on for almost a century, and we still do not have concrete answers whether it is efficacious or not. At least most of these studies have shown that it is pretty safe, but there has been question lingering on the efficacy part. There were some initial studies from, there was actually a review by a group of doctors from India, and they reported in early May, and most of these studies was from China and one from South Korea, that they showed clinical symptoms improvement, but there was no clear-cut difference in terms of mortality. Then there were some studies from Europe that showed actually negative results regarding convalescent plasma therapy. But the most important study, as Dr. Peter Lamich also has mentioned about, is one from the Mayo. Although it was planned to be, wanted to let the audience know that it was planned to be for a few hundred patients, but it was in the expanded access program. So there are thousands of patients enrolled. And I think so they had 35,000 patients that were transfused with plasma therapy. And the good news is that they did see that patients who were given plasma within 3 days and with high titer had mortality benefit. There was 10% difference in terms of patients who received early versus patients who received late therapy. There was 20% mortality in the patients who received plasma therapy, and there was 30% mortality in patients who received late or did not get plasma therapy. This study was very, I think it is very encouraging for all of us. But when I posted this webinar on the different WhatsApp group that I am and on the Facebook, immediately I got this response from the audience that the FDA has issued this and what do you say? And I said, we will comment on that as well. And I think Dr. LaCamera also mentioned, I don't think so the FDA has said that convalescent plasma therapy does not work. I think they did it right. If they would have opened it, we would never find the true answer, whether it works or not. They want us to go and do randomized trials to prove the efficacy. I know it is very difficult during a pandemic because there are different therapies, different antiviral drugs being used. So it is difficult to even randomize and difficult to differentiate. But if we can have a good answer, then it will be good for not only COVID-19 patients, but also for future when we may have similar outbreaks at that time. So I think FDA did the right thing. We should not be discouraged, but that means that we all have to go back and do proper randomized trials to show clear-cut efficacy. So saying all that, if you want me to comment on that question also, although that is not the topic today, maybe I think Muzzamal said that at some other webinar we will discuss about the chronic manifestations. But just briefly, any viral infection can affect the heart. And so, yes, COVID-19 can also cause myocarditis, as you all know, and can cause cardiomyopathy. That's the short answer for that question. And yes, patients who were given chloroquine and were given azithromycin had suffered serious ventricular arrhythmias related to COVID-19 infections.
Great, thank you very much, Dr. Shahab. You know, one of the questions that comes up whenever we're talking about convalescent plasma is, you know, what about plasma exchange, which is kind of a, you know, the polar opposite in some ways of convalescent plasma. And of course, it also seems like an attractive option. One can come up with sort of the scientific rationale for that too. Perhaps it's the bad humors, the evil humors of patients with, you know, COVID-19, especially the sick ones, right? Perhaps all those cytokines that we're trying to get rid of, or whatever prothrombotic factors that might be circulating that we need to get rid of, not add to more of. Dr. Bushra, what are your thoughts about plasma exchange as a therapeutic modality for COVID-19?
I think what we need is some robust animal model to study what constitutes protective immunity in COVID. Because if neutralizing bodies are good enough, then plasma therapy would make sense even without randomized controlled trials, because that there would be a scientific basis for using it. For plasma exchange, you remove the protective antibodies as well. And we know that COVID patients are at risk of developing bacterial and fungal infections, and a large majority of our very sick patients have gone on to develop secondary infections. So I would be a little concerned about using plasmapheresis. I would rather control their hyperimmune response with tocilizumab, which works fine, or you go ahead with IVIG rather than removing plasma. So plasmapheresis, I would be worried about and not actually opt for as treatment of choice.
Great, thank you. And Professor Imran Fazal, just to clarify, the data that you shared, was it all directed towards, convalescent plasma, or were you also using therapeutic plasma exchange? One of the audience members wanted to just clarify.
Well, as far as plasma exchange is concerned, once we are giving uh, convalescent plasma, there's no point in doing plex afterwards because those antibodies would be washed away. So yes, it can be done for those patients where the facilities are not available or the proper donor is not available. Then one can think, in selected patient, one can think of doing plex for these patients just to take them off the load of cytokines. But otherwise, we have not used it simultaneously, just for the reason that once we are pouring in some antibodies in the individual, they would be simultaneously washed if we are doing plex simultaneously. As far as other therapies are concerned, we have been using the other therapies in addition to plasma exchange in these patients. And we have been using it with quite frequently.
Thank you. Yes, thank you for clarifying. And of course, makes absolute sense. Has your institution been using mesenchymal stem cells as well? I think that has come up.
Yes, yes. We have been using mesenchymal stem cells, and the results of mesenchymal stem cells have been really remarkable. One of our patients who we cannot um, save. Apart from this, we have used it in 22 patients, and all of them survived, and all of them were having moderate to severe disease. We are yet to in the finalization of our data, but offhand, I do recall that apart from just one patient amongst these patients, all of them survived.
Thank you. We definitely, look forward to hearing about those data. And of course, COVID-19 hasn't left us. It's probably here to stay, and it may have ebbs and flows. It may become a seasonal nuisance at best. So all of these data are going to be of much value the next time humanity, is suffering big time. And of course, I speak as if we aren't suffering now. It's only really in certain pockets in the world that things have gotten better. Of course, right here, even within the United States, while some states are celebrating, having been past their peaks, others are very much in the thick of things still. So thanks to everyone who is not only helping treat patients, but also contributing to the treatment of future patients by looking at their data more robustly. Does anyone have any final thoughts to share, any other comments to make, or want to answer any questions or pose any questions? Dr. Muzzamal, I'll start with you.
Yes, I can have probably quick. I know we are almost already an hour, so we need to close, but I may have one quick question from Dr. Busher from Karachi. Just to ask, have you tried to use it on other viral diseases? Or is there any potential? I mean, dengue had been a problem in Pakistan from last few years. I may be far-fetched or something. I mean, but I see there may be some potential in other viral diseases too, if we can prove this modality can be useful for COVID.
For dengue, there is an issue because there is this phenomena of immune enhancement. So
I see.
preformed antibodies actually make the condition worse.
I
So
see.
it would be contraindicated
Okay.
for dengue. Yeah.
Okay. And also for another question for Professor Imran, I mean, I think it was wonderful. Your observation was slightly different from compared to what randomized trial, the last randomized trial, which came from China, in which they saw increased trend towards better outcome with convalescent plasma compared to critically sick patients or patients in ICU. Can we go back? I mean, are you following the WHO criteria to classify those patients who are severely ill versus critically ill? I think it will help if we can analyze data and patients to be categorized in the same manner and then compare their outcome and to compare the studies.
Yes, we are following the WHO criteria, and it is exactly the WHO criteria which we are following.
Wonderful. Thank you. Dr. Majid, that's
I'd
it
like to make
from my side.
I'd like to make one comment,
Yes,
and that
please.
is that since because of CRS, we are all concerned about interleukin 6 and then interleukin 6 antibodies, that is teclistamab. Some or the other, what has been our experience is that it is not very convenient and very easy to use this product. One has to be very, very sure that there is no infection, and one has to be doubly sure that there is no the procalc level are within acceptable ranges, and only then we have found good results. Otherwise, there is invariably there are patients go to septicemia. So that is just a word of caution, just to share with you.
Thank you.
Yes, and of course, with the TB being such an endemic problem in Pakistan as well,
Yes, yes.
yet another thing, and just like Dr. Bushra was alluding to as well, of course, a good chunk of patients to happen to have contraindications to IL-6 therapy. Dr. Tariq Shahab has a few comments to make as well. I know we are up against the hour, and if anyone needs to leave, please go right ahead. But for those who are able to stay, thank you. We'll wrap up shortly. Dr. Shahab.
Majid, thank you. I think there was two questions related. One was about cardiomyopathy, whether to discontinue heart failure therapy on patients if they have improvement of ejection fraction down the road. In our institution here at University of Fairfax and GW Hospital, we, and as with any other virus, we see that some patients who have at the start has severe cardiomyopathy within EF of 15-20%. 50% of them go on to improvement. And if their EF improves to 40 to 45%, we still continue heart failure therapy for at least a year till they return to normal. And except for the diuretic therapy, but other therapy we continue. So that was the question that I wanted to address. I think there was somebody also mentioned that about plasma being volunteers in Pakistan selling plasma for this purpose. And I think government has taken a notice of that, and that is being controlled now.
Excellent. Thank you very much. And Dr. Shahab, if you don't mind also posting the URL to your website. Some people have asked for that, maybe in the chat forum, okay. The RT Cure. I did Google it up and I came across an Insta, web link, but perhaps just, whatever is the most, the easiest to access web page as well. That would be great. Dr. LaCamera, would you have any other final parting comments, thoughts, insights to share?
I really, commend those that are collecting data on their convalescent plasma use and the outcomes. The NYU has a platform that allows for investigators to submit their data. It's done under the premise that it's going to be difficult, as we've discussed, to complete these studies soon. And so they've created a platform that allows for different investigators from different studies to submit their data, and NYU will pool it and analyze it and hopefully generate some meaningful and worthwhile analysis from it. So it might not be a bad idea for those of you, again, who have collected data already, just to poke around on the NYU site and see what they have to offer there, in the spirit of sort of everybody working together and collaborating to make a difference here.
Great. Thank you very much. Thanks everyone for joining in today for another lively and highly educational webinar. Thank you very much. And please join us again, same time next week. Take care and all the best to you and to your patients. Thank you.
Thank you. Thank you, everybody.